Good morning, good evening to all of you from whichever part of the globe you're logging in. And we welcome you all to this. I'm Dr. Vishwanath, Senior Consultant and Medical Oncologist at Apollo Hospitals in Bangalore, India, and also the Managing Trustee of CPOM Foundation. We welcome you all to the first of the 2025 series of the ASCO Endorsed CPOM Foundation webinar. And it's a very important and interesting topic. It's on access to oncological drugs and clinical trials between the US and the low and middle income countries. So a few ground rules before we start. Um, ensure that you have a good internet connectivity for a seamless experience. And all the attendees will be in mute and listen only mode. Attendees can ask questions by typing in the Q&A section. And this session is being recorded. So a few words about our organization. It's a not-for-profit organization. It stands for Creative Portal for Oncology, Education, and More. And this organization is tasked with educating practicing oncologists and trainees and a portal for increasing access to patient resources and improving access awareness globally. So this is our team, myself, and then Dr. Santhosh, Devadas, Dr. Poonam, Dr. Chandrakant, and Dr. Rachin Chite, all of us medical oncologists from various parts of India. So today's agenda includes welcoming remarks after this by Dr. Robin Zahn. She's been very kind enough to send a video recording of hers. And then this will be followed by a keynote address by Dr. GILBERTO Lopez. Thank you so much, sir. And then followed by two panel discussions on the access to oncological drugs, and then on access to clinical trials, and then a nice summary and concluding remarks by Dr. Poonam. So we'll have the welcoming remarks by Dr. Robin Zahn, who is the current president of the American Society of Clinical Oncology, and she is also the director of breast cancer oncology at the Cincinnati Cancer Advisors. So let me share her recording.
Greetings from Granger, Indiana. I'm Robin Zahn, president of the American Society of Clinical Oncology. Today, I am pleased to welcome you to this ASCO-endorsed CPOM webinar on access to drugs in LMICs versus the U.S. ASCO's membership in India is extensive, having grown significantly over the last few years, and we are excited about this increased engagement on an individual level will further our collaboration with wonderful organizational partners in the country. Partners like Creative Portal for Oncology Education and More Foundation, or CPOM. Since its establishment in 2021, CPOM has shown itself to be an online education and community platform that is in alignment with ASCO's own ideals and values, utilizing technology to further its mission of spreading knowledge about cancer, its treatment, and care. This webinar series with CPOM, addressing prevalent issues in cancer for LMICs, is the latest in a multi-year collaboration between our two organizations. Our previous webinars focused on specific disease types were a great success, offering attendees a wide array of information and perspectives on oncology care. Today, we have an impressive group of panelists ready to contribute to this ongoing conversation with discussions on access to oncology medicines and clinical trials in LMICs and the U.S. We hope that you find the session to be both informative and engaging. Thank you to our panelists for lending us their time and expertise today. And a special thank you to Dr. Vishwanath S., co-founder of CPOM, and the driving force behind this series. Together, we are stronger than cancer, and I and all of ASCO thank all those involved in the creation and implementation of this thoughtful and important series. We look forward to future webinars and the discussions they generate. Thank you, and enjoy the panel discussion today.
Dr. Gilberto Lopez will be giving a talk on global access to a global landscape of access to the oncological drugs, and it's going to be a keynote address. And he's a professor and chief of the Division of Medical Oncology and associate director for the Cancer Center and medical director for international affairs at the Sylvester Comprehensive Cancer Center in Miami. And welcome you, sir, and look forward to your talk on global landscape of access to oncological drugs. Over to you, sir.
Thank you very much for the invitation and for having us try to summarize 20 years of work in 20 minutes. So without any further ado, let's just try to do that. These are my potential conflicts of interest. And truth is, when we practice in the US, we don't necessarily realize how different the situation can be in low-income countries. Here, we know that since the 1990s, we have seen cancer death rates drop by more than 30%. And overall, and these numbers are probably even better now, 2/3 or more of the patients that have a diagnosis of cancer live for 5 years or longer, compared to less than 50% a number of decades ago. For those of us treating patients in low-income countries, however, these advances are clearly an inspiration and they do bring hope for the future, but they are not our current reality. These are cancer mortality to incidence ratios, which are a very crude way of looking how we're doing overall. And we see that while that ratio, as I mentioned, in the US is about 1 to 3, 1 death for every 3 cases. In Europe overall, it's about 1 to 2, and in the LMICs, it's actually 2 to 3. So this is a very crude way of showing that we need to do much better. And as we have gone forward with the concept of magic bullets as well as immunotherapies, this gap is actually increasing. Imatinib, without a doubt, for many of us who treat CML, has been a game changer. It has made patients that had an invariably fatal disease be able now to have survival that is in parallel to individuals that do not have CML. But unfortunately, for those of us treating solid tumors, as they're more complex, we really don't see the same benefit. But over the last few years, we have made a lot of strides. I mostly treat thoracic oncologists today at the cancer center, and osimertinib is a great example of a targeted agent that changes prognosis markedly in lung cancer, not only improving progression-free and overall survival, but also having less toxicity than the first generation of TKIs. And in addition to this, of course, immunotherapy has been one of the major advances that has improved the length and quality of life of patients with thoracic malignancies, with lung cancer in particular, in the United States, with overall survivals that now can certainly reach at 5 years about 30% if you're PD-L1 positive, or 15% overall. Unfortunately, even though these treatments are extremely effective and available in high-income countries, even that when you look at them through a prism of cost-effectiveness health technology assessment, they really aren't as cost-effective as we would like them to be. And that's true even for osimertinib in either the United States or Brazil, as in this study that we did a few years ago. And in addition to that, low-income countries invest a lot less in cancer control than high-income countries do. This is a study we did almost 20 years ago. It's one of my first forays into global health policy and access to medications. We showed that that countries such as the United States, you spend hundreds of dollars per each case or per each diagnosis of cancer in the country. And that is also true in places like the United Kingdom and Japan. But when we look to the global south, we see that in South America, the average is just about $8, and in India, 54 cents. And these numbers hold and continue to look pretty bad, even when we look as a percentage of GDP per capita as well, as you can see in the numbers between parentheses. It did take us a long time, and through UICC, we were on the founding members of the Non-Communicable Disease Alliance, and it was the NCD Alliance that actually came to the UN and finally had the second ever high-level meeting for the UN. And we had some in HIV back in the 90s, but this was the very first one since the AIDS crisis, and this was in 2011. So it took us about 10 years to convince member nations that non-communicable diseases are the main cause of death, even in the lowest income countries today, surpassing clearly infectious diseases as well as maternal health issues. Of course, those are still extremely important. There's a lot we need to do in infectious diseases as well, but most people, even in the poorest countries today, actually die from NCDs. And that's why we finally were able to start getting the UN, the WHO, and all of the global health organizations to focus not just in the prevention of cancer with tobacco control, but also into looking into diagnosis and treatment. This was the first review of the WHO Essential Medicines list in 10 years when we did it back about 10 years ago. And we looked at those medications for which treatments truly led to a cure or to very good control of the disease, or also taking in consideration how common diseases were, and of course, cost effectiveness of each specific treatment. And with that, we were able to convince the WHO to have a new total of 46 drugs, many of which are generic and are chemical entities that are relatively easy for us to make generics, but also got a few more expensive drugs. And to this list from a few years ago, we now can also add a few more targeted agents and immunotherapies and monoclonal antibodies. But these were the first three then expensive medications that were included in the list: imatinib for CML and GIST, trastuzumab for breast cancer that's HER2 positive, and rituximab for lymphomas that are CD20 positive. So great news. This happened back in 2014, 2015. On Monday, after we had that meeting over the weekend, everybody had access to these drugs, right? We wish. By adding these drugs, this is one example, by adding trastuzumab, of the cost implications of newer drugs on patent protection and more innovative. We see that the cost for AC with paclitaxel and then hormone treatments with tamoxifen is about $273. By adding trastuzumab, that gets to $40,000. And of course, this is something that most low and middle income countries can't afford. Why does it cost so much to bring to get a new drug? Why do new drugs cost so much? It is a little costly. Actually, I'll show in a slide that it takes billions of dollars to develop a new drug today. And the main reason is because we have to screen thousands of compounds to get a few hundred compounds that are good drug candidates in preclinical testing. For every 5 drugs we get into phase 1 and 3 clinical trials for each approved drug that we have in the market. And today, that cost is in excess of $3 billion, and we can discuss how much of this is financial cost, how much of this is actually money invested in drug development, but it is clear that it's becoming more and more expensive to bring new medications to market, and because of that, they have become ever more expensive. Osimertinib in the US can easily cost $30,000. Of course, no patient can afford that. Insurance is necessary, but even a copay at $3,000 is difficult to pay, even in this country. How can we increase access then when these medications are so expensive? These are the most important effective options. We have done seminars with the WHO, IAEA, ministers of health around the world, but these are some, and we can certainly talk about this for more than 2 weeks in these courses, but these are some of the most important and effective options: having quality generics and biosimilars. And I'm going to discuss a little bit of each one of these, including the concept of compulsory licensing and how it has been used to try to bring medications that are still under patent protection to low-income countries. We're going to talk about the economic concept of price discrimination, which is probably better called affordable pricing or price tiering. Nothing can really work without adequate healthcare funding with universal coverage and maybe value-based insurance design. And I'll finish by discussing public-private partnerships, of which the ATOM coalition that I lead is one of the examples that is trying to have a more comprehensive way of bringing also on-patent medication into low-income countries. This is a study I did more than 10 years ago. This was looking at access to new drugs in Southeast Asia. At that time, I was living and practicing in Singapore. And we saw that even in Singapore, which is a high-income country, for a basket of new medications, some of these medications now are old and not on patent protection anymore. But even in Singapore, only about 60% of patients were able to get those specific treatments. And when we looked at predictors of access, of course, GDP per capita, as expected, was one of the most or the strongest predictors, but also the cost effectiveness of the drug. So even though none of these countries, except for Thailand back then, used formal health technology assessments to bring drugs to their systems, doctors, patients, and the market in general was actually making some sort of rudimentary cost-effectiveness assessment and deciding if it made sense to use these drugs. And again, these drugs were new when we did that specific study. And that brings us to the point that we need to be able to improve cost effectiveness. And we can do that in only two ways. We can do that by decreasing cost or by increasing the value of cancer medications, by making drug development cheaper and more effective, and by also making each treatment more cost effective. The use of biomarkers has been useful. And of course, to bring prices down, we need to use generics, biosimilars, and the concepts of both price discrimination as well as access programs. We and others have shown what we see in this slide, that many different studies show that the more we use biomarkers, the better the cost effectiveness of agents. And here I show just a few examples that were new when we started doing these studies more than 10 years ago. We also showed, and this is something that very few groups have, that when we use biomarkers in the drug development process, we actually increase the rates of success for drugs by 50% and decrease the cost by about 30% in breast cancer and by similar numbers in lung cancer as well. So this shows that we absolutely should be doing what we do today, which is to use biomarkers, not just to select therapy, but also to develop new treatments. But without a doubt, it is generics that have been able to bring a number of medications that would be cost prohibitive as innovative medications, and that once patents expire, we can actually use. In the United States, generic medications account for more than 90%, 90, of all prescriptions, and these represent only about 20% of the cost. So they're 90% of the medications and only represents 1 in 5 of the dollars used in medications in the US. And indeed, the cost of a drug can drop by 80 to 90% once enough generics are introduced. In the US, we have calculated that the use of generics has saved more than, by now, $2 trillion a decade as time goes on and we use more of these. And we have shown, and these are some studies that we published about 10 years ago as well, that you can save hundreds of millions of dollars in low-income countries, and that as long as the generics are of quality, you do not sacrifice any efficacy for bringing them and for having patients using them. There have been difficulties with biosimilar. In the US, it took a while for us to see a price drop in biosimilars. What you see here in this slide is what the cost of the medication was, and this is trastuzumab, how much it actually cost with the originator brand, of course, 100%, and how when the first 3 biosimilar drugs came in, price did not really drop much. But finally, when we have 5 biosimilars, that price has dropped by 60%. So not quite the 80 to 90% that we would expect, but pretty much a lot more than it used to be. So you do need competition. It's not just about having one generic or one biosimilar. You need several so that markets can work. Otherwise, we do need intervention. Of course, there's challenges. A lot of patient and healthcare workers have a perception that generics are inferior, and they can be. There may be quality issues. And today we do have a lot more experience with biosimilars, but this is way less than we have with generics. That brings us to compulsory licensing. This is a dispositive. This is a part of the rules in the WTO, the World Trade Organization, coming from the trade-related aspects of intellectual property agreement that went in effect more than 30 years ago. This is commonly referred to as the TRIPS agreement. And this allows countries to produce and or import generics while medications are still patented on grounds of public interest. We use this widely in Brazil and South Africa for AIDS medications, and I'll show you a few examples in which it has been used for cancer medications. I always like to remind people that even high-income countries use compulsory licensing in different situations. The US threatened to use compulsory license to make Bayer sell them ciprofloxacin at much cheaper prices during the anthrax scare that followed the 9/11 attacks. So here are a few examples of compulsory licensing in oncology. In Thailand in 2008, the government issued compulsory licenses for docetaxel, letrozole, erlotinib, and very briefly for imatinib once before an agreement was made with Novartis. And they actually had savings in excess of $140 million. India, and again, India's regimen is a little bit different. license for sorafenib. The problem with this is that there may be decreased investment, and you can have clear retaliation when countries use compulsory licensing. Pfizer pulled out of a new plant factory when the military in Egypt decided that Viagra was a good medication for compulsory licensing, and that shows you that the priorities in a country may depend on who the rulers are. And again, the consequence was that Pfizer canceled a plant factory that they had near Cairo. And the US actually withdrew duty-free status of 3 Thai products when Thailand actually issued the compulsory license in cancer medications. That brings us to the fact that I believe compulsory licensing is an important mechanism, but it's probably best used as something that you use to negotiate prices. And that's what Brazil and other countries have done very successfully with AIDS medications in the last 20 years. That brings us to the next economic-based concept, which is price discrimination. This just means that when you have a product or a service that it is expensive to develop, let's say movie, it costs today $100 million to create a movie for the Avengers, let's say, or even more if it's the Avengers, might be 300 or more. But once that cost is there, for you to show it in one more room, it's actually very little compared to the overall cost of developing it. And that's the way medications work. So for movie theaters in countries like the US, if you go on a Wednesday, that's going to be in the afternoon, that's going to be a lot cheaper than if you go on a Saturday evening. And that is used in a number of different markers for a number of different products. And it can be used in medications as well. If you do see that the cost of developing a medication is $2 billion, the cost of actually making one extra tablet can be as low as $1 for a lot of our targeted agents. But this is a concept that back in the early 2010s was not really used at all. So this is the price for those medications that I mentioned in the study that we did in Southeast Asia, showing that the prices were pretty much similar. And it did not matter if you're in a high-income country such as Singapore and Brunei, or if you are in a lower-income country such as the Philippines and Vietnam. Back then, we started working on a number of pilot projects, and that has made industry, at least most of the major players, realize that they can make more money and increase access by having different prices in different markets. And today, this is actually the norm, and that comes from discussions and lobbying and advocacy efforts that we made more than 10 years ago. And we will see that unfortunately, nothing is perfect. You can have parallel imports, and that would negate the benefit and probably create political backlash in high-income countries, especially in times of economic difficulties. Most of the people I speak with in North America and in Western Europe, they really don't mind if prices are different and are lower in low-income countries. What Americans really hate is to pay more medications than what Canadians pay. And I think that that's where the political difficulties are. And unfortunately, lower prices, if you have a medication that costs $30,000 and you still need to pay $3,000, that's a 90% discount. It is still nothing that can be afforded by somebody living on $2 a day. So only doing this may not be enough. I'm not going to talk much about participating in clinical trials as a way of bringing access. I know that we'll have a bigger discussion about this in the panel, but there are issues related to it as well. So I'd love to bring that for discussion too. And we really need to find new innovative payment methods that would help. I used to have something else in this slide, which was a global fund to treat cancer in low-income countries. And that's an idea that has been pretty much thrown away by a lot of global policy and global health companies and groups and thinkers, if you will. It is finally making a comeback, so we can discuss that if you like. But let me just discuss a couple of little things that bring us an example of why this could be effective and what brought us the inspiration for ADAM, which I'm going to talk next as well. So the Gavi Alliance, the Global Alliance for Vaccines and Immunization, and the International Finance Facility for Immunization have truly revolutionized the way vaccines are marketed and brought into low-income countries, truly improving access and saving millions of lives with vaccines. So an additional 300+ million children have been immunized because of Gavi's efforts, and 5.5 million premature deaths have been averted. In cancer prevention, Gavi has made vaccines such as the hepatitis B as as cheap as 50 cents per dose. And of HPV, this is an old slide that's now down to about $1 in their efforts as well. And that is the inspiration for us to create ATOM. We know that today more than 3.5 million new cancer cases happen in low-income countries every year, and an estimated 2.3 million premature deaths. Remember, 2 deaths for every 3 cases. So we really need to improve access. Of course, we need to improve everything. We focus on access to medications because that's the lane that was least occupied and that we thought we could make a difference as UICC and as the new coalition. We are aiming to work with about 40 plus countries that represent 3.6 billion people, about 45% of the world population. And the founding partners were UICC, the Medicines Patent Pool, which was the institution that was able to not just do compulsory licensing, but especially voluntary licensing for HIV medications, and a number of different players, including industry, including NGOs, cancer centers, and I'll show you a slide with a number of our partners. So we are a public-private partnership, and I'm going to show you a few more details. These are some of our 40 plus partners, including pharmaceutical companies, and not-for-profit entities such as IDA, which is a Dutch foundation that has helped us create some of the mechanisms to which that we use to bring medications into low-income countries today. We have 4 main ways, and we could probably put 2 of those together, but what we have is a donation model that is mostly executed by the Max Foundation, which has done really brought access to imatinib to most low-income countries in the world, financed by Novartis while the drug was still on patent, providing about 30% of all imatinib that they produced for free through the Max Foundation. Voluntary licensing is the other mechanism, and we today have the first voluntary license for a CML drug as well, and we're working on a series of others. Nilotinib is not a priority medication in my book, but it is the first ever example of a voluntary license for a cancer drug, and we hope that that's going to just open the door for many more to come. And we have created a platform that actually solves one of the main problems we see in low-income countries, especially small low-income countries. Because you have relatively small markets, you end up getting higher prices than what the United States pays for generics as well, and it makes it hard to compare and to know the quality of the product. So we created the NCD Connect platform, which is executed and run by IDA, the Dutch foundation I just mentioned, and that helps us bring these medications to low-income countries. We are now working specifically on 3 different countries as our pilot experience, and we hope to be able to bring information. And the ministries of health of El Salvador, Zambia, and Mongolia have agreed, and we are deep into our assessment of needs, and we'll be working on implementation in the next phase. I'm going to stop here. Without a doubt, we have made significant improvements in the treatment of cancer over the last 20, 30 years, but most of these new drugs are not available in low-income countries, and many of the generic drugs that we need to use are not available either. The WHO Essential Medicines list finally has included a number of new innovative treatments, and we really need to continue developing multi-sectoral, multi-stakeholder initiatives such as the ATOM Coalition to address these disparities. So thank you very much for being here, but especially thank you for everything that you do for your patients around the world. Let me stop here and stop sharing so that we should have time to come into discussion.
Yeah. Thank you, Dr. Lopez, and for that wonderful talk.
By Vishwanath. Oncology, Associate Director, and from Henry Ford Cancer Center, Detroit, Madam Dr. Roselle D. Guzman, medical oncologist from Manila Central University, and Dr. Abiola Ibraheem, Assistant Professor of Medicine, Department of Medicine, Division of Hemato-Oncology from Chicago, and Dr. Santhosh KD, who is the founding trustee of SIPOM, Head of Medical Oncology at Rama Institute of Oncosciences, Bangalore. Over to Dr. Vishwanath for moderating research.
Thank you so much, Dr. Rachan Shetty, and thank you, Dr. Lopez, for that wonderful talk. And thank you all the distinguished panelists for having given your time for today's very, very important session. So the first panel discussion is going to be on the access to oncological drugs. And so just to start with so basically for over the past decade, oncology has witnessed remarkable advancements in drug development and approvals, and rising costs and inequitable access have led to significant disparities in cancer outcomes worldwide. And the staggering 70% of total cancer mortalities occur in the lower and middle income countries, what we call as LMICs, underscoring a significant disparity in the lack of access to essential oncology medicines and diagnostics. And we know that majority of the new patients and cancer and deaths now occur in the LMICs, which accounts for 57% of all the new patients with cancer and 65% of all the deaths. So with this background, let's dive into the questions, and we have Dr. Lopez and all the other panelists who are going to be who are experts in this and are going to participate in this panel discussion. Let me start with Dr. Lopez. So you spoke about insurance and out-of-pocket expenses. So how does insurance impact access to novel cancer therapies in a high-income country like United States? And what steps are being taken to address these disparities?
That's a great question because it makes us realize that it is not only in low and middle income countries that we see access issues. We see many access issues in high income countries as well. And that may be in general populations, that may be in minority populations, that may be in underserved areas as well. And if you don't have insurance in the US, it's much harder. But to be truthful, most pharmaceutical companies actually have programs in this country that help patients as long as they are in the country legally. Sometimes it is difficult for them to help undocumented immigrants, but sometimes we are able to get medication, especially oral medications. If you don't have access to the healthcare system, however, and that's the main issue, if you have delays in getting access, and that still happens for a significant minority of the population, even after Obamacare, we still have a number of people that either live in states where Medicaid has not expanded by taking federal money, and there's still people that cannot afford insurance even with Obamacare. So it is an issue maybe for 10 to 20 million people in this country. And of course, there's different barriers. There's barriers in terms of you being able to make a copayment that can, again, be about $3,000 a month. But here, there are usually access programs that pharmaceutical companies use, and they do help patients. And of course, they do help them sell more drug, because if patients cannot afford the copay, they would not have access to the drug.
Yeah. Very well said, Dr. Lopez. And like you said, in spite of the Obamacare, we have a significant percentage of the patients in the United States who are uninsured. And those insured also suffer from significant financial toxicity that leads to delays in seeking treatment. Like you said, patient assistance programs are there. And Dr. Sirish Gadgeel, so what do you think could be the possible solutions for this kind of a situation, which is occurring even in a high-income country like the United States?
I think that it needs to be approached comprehensively. I mean, I think the topic here is drug prices, and that is very critical. But you're not even going to be able to access drug prices if you are not going to, like Dr. Lopez, I'm also a thoracic oncologist. And the first step now in assessment of lung cancer patients is, getting molecular profile and NGS. And um, sometimes it is becoming less and less. It is difficult to obtain NGS testing on patients. And so if you don't know the appropriate profile of the tumor, you're not even going to be able to recommend the right treatment. So there needs to be a lot more comprehensive sort of assessment of the totality of the issue and then addressing it. I will also tell you, and part of this I'm telling you because I don't know the exact solutions. I'm telling you the problems that we are facing. We're talking again about drug prices, but it was very, very difficult as a lung cancer oncologist that about a year ago or a year and a half ago, we were not able to access cisplatin and carboplatin. there was a shortage of that drug. And think about how challenging it was that here you had all these wonderful immunotherapy drugs and targeted therapy drugs, but the immunotherapy drugs are used in conjunction with drugs like carboplatin. And as the business model has altered, where these drugs are not very profitable, but still very critical in the management of the patients, we don't have access to it at times. Yes, now the solution, it has been looked at. So I think drug prices is one aspect, but I think delivery of care needs to be looked at comprehensively, and drug prices should be one component of that. And then the final thing I'm going to say is, um, what Dr. Lopez mentioned, I live on a border state, the northern border, where we have Canadian patients. And yes, it creates a question as to why can't patients access drugs from Canada if the prices there are lower? Of course, we are in an interesting political situation where Canada may not be such an ally and friend these days as it was just a few months ago. But these things can become challenging. And so there is this perception that everything is accessible in the US, but on a day-to-day basis, there are access issues that do impact drug costs and drug accessibility. Molecular testing, certain basic drugs that have to be given in conjunction of these novel drugs, and a perception that Americans are paying a lot higher cost for these drugs, and that is impacting access.
Great thoughts. Like you said, Dr. Gadgeel, it's not only about access to oncological drugs, the cost, but it's also about the entire cancer care access. Dr. Lopez, so a few more questions to you because you'll have to get going. So, what are your thoughts about this fast follower drugs and whether it, now we are seeing a lot of ASCO is global. We are seeing a lot of drugs, which I mean, the lot of abstracts which are coming from the global world, and these fast follower drugs are going to reduce the prices. What are your thoughts on this?
So we used to call them Me Too's, and now we call them fast followers. And there are a little bit of semantics that are different between Me Too drugs and fast followers. The general idea is that by knowing that a target is clearly important in controlling disease and in treating cancer, you could develop different molecules that would target, let's say, PD-1, PD-L1, because we have a concrete example there. And by using that, you can abbreviate the drug development, and it becomes a lot cheaper, and you wouldn't need to spend $2-3 billion to bring a drug, but maybe just a few hundreds of millions of dollars. And that has happened. We can see fast followers in targeted therapies. We have, for instance, icotinib as a first/second generation EGFR inhibitor. We have now aumolertinib, which is the third generation. And in immunotherapies, we have a number of PD-1s and PD-L1s that have been developed in China. I'll mention sintilimab and toripalimab, just to mention two of them. And they do have the potential to bring prices down. In the US, that hasn't quite happened. We don't really see a lot of competition. There has been a lot of political meddling, if you will, in the decisions of the FDA. And eventually the FDA decided that we already have enough IO drugs in the market. We do have about 10 of those if we count not just PD-1, PD-L1s, and we count other ones. But in China, the prices of these medications are about 10% of what they are in the US. And one of the main reasons is the availability of fast followers, and that has forced even branded drugs by BMS and Merck to be brought down in price in China. It has involved government intervention as well. It wasn't just the availability of local Chinese makers. The government pretty much forced companies to come in and give a deep discount. So there is potential. And as anything in life, it's in not just in the eye of the beholder, but also the devil is in the details. So it depends on how we make it happen. We have to keep the balance that if we really get away with patent protection, we may see a decrease in investment, and we may see a decrease in new drugs in the future. Although many of us contest that logic, The Congress Budget Office, which is the nonpartisan entity within the U.S. Congress that looks at the outcomes and the potential outcomes of new legislation, has looked into the potential decrease in innovation based on the Biden administration law that is hoping to control those 10 medications that are mostly used in Medicare. And the CBO, the Budget Office, does not believe that those changes would impact investment in new drug development and would not really impact the number of new innovative drugs coming forward. But of course, all of this is subject to debate, and we will have to see as things move forward how that will develop as well.
Yeah, great thoughts, Dr. Lopez. Apart from this, I think the Center for Medicaid and Medicare to negotiate prices and then insurance penetration, we're going to come to the biosimilars and generics. That's a different topic, but great thoughts. So let me shift focus to our LMIC oncologist, Dr. Roselle. I think it's very similar in Philippines and India. So we face a lot of out-of-pocket expenses for cancer care. And how do you think it impacts outcomes and the accessibility, and what kind of challenges do we face?
Yeah, I completely agree, Dr. Vishwanath, that we both face the same challenges in terms of access to cancer medicines. So, for example, in the Philippines, the high out-of-pocket cost for cancer care is roughly about 45% is being shouldered by the patients and the families. And how does that impact outcomes? Of course, we have seen a lot of cases of cancers that are in the advanced stages because even access to screening, the basic infrastructure for screening is not quite accessible for a majority of the population. And in addition to screening and early prevention, even the most preventable cancers like liver cancer, cervical cancer, which can be prevented by vaccination, is not well covered by the national health insurance. We do have the Philippine insurance coverage, which covers more than 90% of the total population in the Philippines. However, it's not enough to cover for the whole cancer care continuum expenses. So there's mainly restricted to public hospitals, and there may be coverage in terms of insurance, both public and private, but still not enough to cover for the more commonly used medicines now, including biologics and immunotherapy. So the way we're seeing now is that the high cost of cancer care, specifically the government support, which for healthcare is only about the GDP is only about 6%. So it's really not enough to cover for the cancer care from screening, prevention, up to treatment and palliative care. So what we're having now in terms of providing more access is more of a public-private partnership between the government covering some of the expenses, and as well as private institutions, foundations, and organizations that covering for some of the cost for these cancer drug payments. So the Philippines now has a strongly moving forward in terms of implementing the cancer law, which was signed 5 years ago. And the cancer law promises to strengthen the cancer care of the Filipino people. However, it's still very early in its phase. And well, what's good is the collaboration between the government, the medical societies, patient advocates. So in order to streamline everything. So currently what we need here is streamlining from realizing that a lot of government spending for healthcare would be saved by implementing and really very strong in increasing awareness on screening and prevention.
Yeah.
Rather than treating and managing cancer at the advanced stages.
Yeah. I'm sure Dr. Guzman, the situation is it's almost very similar in India, and there's a significant amount of catastrophic expenditure. Like you said, the GDP, it's 6% in Philippines, it's around 2.1% for GDP, which is spent for healthcare in India. And like you said, immunotherapy is not covered by most insurance companies and oral targeted therapies as well. Dr. Santhosh, what do you think are the solutions for this particular situation?
So, Dr. Vishwanath, thanks for the question. I work in a hospital that does have the India's scheme that help patients from poorer background. That is the Ayushman Bharat scheme, where cancer patients do get access to free treatment. However, the challenge that we face is specifically if it is a finite treatment for say 6 cycles or few cycles, the scheme is able to cover the care free of cost. And we are able to manage even monoclonal antibodies like trastuzumab and rituximab. However, the bigger challenge would be with the chronic care for example, for a drug like osimertinib or for a drug like dasatinib, where a long-term treatment is required and the scheme fails to encompass these treatments. And that is something the governments and the stakeholders need to look at specifically. And other area of concern that we have is management of sicker patients with, for example, hematological malignancies, where there is a very limited government support and we struggle to take care of these, even the curative patients. That is again for governments to look into specifically. And we are glad that the Indian system has the Ayushman Bharat scheme and various generics that are very liberally available. Other concern definitely is the quality of these generic drugs that is not very well regulated.
Yes,
and all these facts are important in decision making at the highest level.
Yeah, well said, Dr. Santhosh. And apart from this, like you said, there are other things like, making cancer drugs part of the NEML, the essential medical list, by following the WHO guidelines. And there's also what is called as the value-based insurance design. So the patients end up paying less for the out-of-pocket copay is much lesser for the high-value drugs, which give good clinical increment versus the ones which do not give that much of clinical increment. And of course, we should also thank our finance minister. I'm talking about Indian perspective. So in fact, there are certain cancer drugs which there is an exemption of the customs duty. It was announced this year. And this has actually brought down the prices of certain expensive drugs by around 10 to 15%. So the next topic is about inconsistent drug pricing. Request the panelists to be concise. That way we can have a fruitful discussion. Let me go back to Dr. Abiola Ibraheem. So what do you think? You are actually a hybrid. You said you want to talk about Nigeria and the US. So we would request you to give your thoughts about, as a US medical oncologist, how does inconsistent drug pricing in the US affect patient access to oncological treatment?
Thank you. So first of all, I think that I have a very special opportunity, which is I have the ability to practice in Chicago and also in Lagos, Nigeria. So I see in real time what the differences is. And honestly, it's like night and day. So when we talk about inconsistent drug pricing, and the thing is we start thinking about it as unequal access, where wealthier countries or wealthier regions, even within the same country, even within the same place, like in Chicago, where you see that people with high socioeconomic status are more likely to have access to treatment. When we talk about drug pricing, it's not only the drugs itself, it's the access to treatment as a whole package. I think I would like us to look at it as a whole package, because cancer care is not just dependent on drugs alone. Even the things that we do the procedures that we do is part of the whole thing. And because of this inconsistent drug pricing, where we say that pharmaceutical industries are more likely to go to places where they're going to get the big buck for their money, right? Then you see that there's actually delayed access to new treatments in other regions that do not have that opportunity, or who are like low-resourced communities in the United States or low-resourced countries abroad.
Perfect. And the cost of novel drugs, like you said, is very high in the US, and that's probably because of poor negotiation of drug pricing by key players. And there's also patent-driven monopoly. And then this middleman, what we say is, the pharma drugs are priced at one level from the pharmaceutical companies, it comes at a certain price. And then what is being sold at is at a different price. All these are different other factors which are probably contributing. So, Dr. Gadgeel, so this inconsistent pricing, such high pricing, do you think we spoke about the fast followers drug and then negotiation by Medicare and Medicaid? Apart from this, do you think any other innovative pricing models like tiered pricing based on different countries or based on the incremental benefit would be useful?
I think so. I think that there needs to be a better incorporation of what is the true value of the drug to the patient in deciding the price. There is always a concern about would overregulation actually land up increasing the price, and there needs to be a certain level of caution when implementing such strategies. But I think different strategies to ensure that the drug price is not somewhat arbitrary. An example that comes to mind, and I'm not a hematologist, but I understand imatinib's price actually kept going up despite no, further sort of uh, additional data. Yes, there's data now in GIST, but there didn't seem to be a necessary correlation with what the drug could achieve, but the price kept going up. And so, better kind of regulation of such drug price increasing and correlating with outcomes is going to be critical. I think the other issue that comes up quite commonly is these programs by the pharmaceutical companies, the assistance programs. And I've wondered, and this is, I really don't have any data, but I've sort of wondered whether there could be a possibility of either curtailing those drug assistance programs and actually, or eliminating them and then lowering the price overall. Is sometimes I've wondered whether the pharmaceutical companies justify keeping the price high, and this is pure speculation on mine, and they by demonstrating these patient assistance programs, and sort of wonder whether there may be a possibility of actually bringing the price down and improving accessibility uh, by curtailing or eliminating these programs. So I absolutely agree. There needs to be programs such as tiered pricing, correlation with outcomes that need to be implemented. My concern always is that can one regulation actually land up in the long run impacting the drug price negatively? It needs to be done carefully.
Yeah, great thoughts. So apart from this, the very expensive treatments, Dr. Westin is here. So we have this CAR T cell therapy, which is so expensive, and there's something called managed entry agreement. In fact, I read a lot about this. That's how I figured out that very expensive drugs or new novel treatment options can this kind of a government and pharmaceutical industry coming together can is the concept called managed entry agreement can also lead to lower drug costs. Going back to Dr. Roselle, if you can be precise, in what about your thoughts as far as a lower middle income country oncologist about inconsistent drug pricing, and what strategies would you think can improve this problem?
Well, the inconsistent drug pricing, how is it affect? It widens the existing inequity. So for drugs, for example, the innovator drugs and the more expensive biologics and immunotherapy could be afforded by wealthier patients or those who have good insurance coverage, whereas those patients who may not have all the means, and we have seen patients who, just because they want to be cured, they want to be treated, they would sell a piece of land, they would sell properties just to be able to continue on with their treatment. And we have seen a lot of patients who have treatment abandonment just because of variations in drug prices, or if they need to be shifted to a different protocol just because they had disease progression. So this inconsistent drug pricing further widens the inequity. And another thing is that with what we're doing now and what the government and the pharmaceutical companies are working together is to provide coverage independently. For example, the national insurance would cover maybe 10% of the drug cost, while the pharmaceutical company could cover a smaller percentage of that, and another fraction may be covered by an out-of-pocket system. So it's more of a pulling together of all the funds coming from different sources, just for the patient to be able to go through these important cancer treatments. Now, pharmaceutical companies provide tiered pricing depending on the socioeconomic status. So there's a third party who evaluates, we call it means testing, to evaluate how much the patient or the family could afford for each cycle of treatment. And then from there, they decide what would be the percentage of discount that patients may be given in order to go on with their treatment. And that's one thing that could help provide better access for
Yes,
them.
Dr. Roselle, like you said, there should be transparency in the drug pricing, and pooled drug procurement is one other aspect. And then, of course, we have Dr. Lopez, part of the Atom Coalition. We'll have his last thought, some thoughts from him in the end. So again, so I think this we spoke about biosimilars and generics. Let me ask this question to Dr. Abiola Ibraheem about what are your thoughts about this biosimilars and generics from a US oncologist point of view and an LMIC point of view. What do you think is the problem in the US? Why is the US not adopting biosimilars and generics so easily?
Okay, before I quickly answer that question, I have to add something else. As far as the LMIC with the previous panelists, we have to also start thinking about, can we actually do research and production of some of these therapies within the region, like in African countries? Then hopefully it will be cheaper. You know, we'll start thinking of drugs and not just rely on importation. So as far as biosimilars and generics, so the thing is, we just honestly don't think that this is as effective. You know, most providers, when they think about biosimilars, you know that when you change a molecule, there's a concern that it's not as effective. And the truth of the matter is that it's not passed through the same rigorous clinical trials that has gotten the initial therapies actually approved. And then we also know that there's also this challenges with insurance companies that wants to force you to use generics. And I have a lot of patients that lose their mind once they are on generics. And I will now flip it to low middle income countries. You know, the problem is our healthcare system is not strong enough for us to actually continue to monitor these generics or biosimilars, because then there's a lot of importation of everything coming in. And I've seen in real time whereby the outcome of patients with these biosimilars is questionable. And now I begin to question the integrity of the biosimilars that I'm using in Africa. And because of that, I started deciding not to practice in Lagos. So thinking about the role for us to actually address this is maybe if we kind of re-educate providers as far as biosimilars and generics, and also start thinking about the rigorous process at which these biosimilars and generics is made available to us as providers. And even when you look at the difference, right, it's not impressive. The difference between the cost of biosimilars and what we really have is like what, 20-30% less, and even most low middle income countries healthcare systems still cannot afford it.
Thank you, Dr. Ibraheem. Dr. Santhosh, quick thoughts. We're running out of time. Quick thoughts about your I mean, your thoughts about biosimilars in India and how it's kind of penetrated and how it's made it more accessible, and what can be done about this to improve the efficacy of biosimilars.
Uh, Thank you, Vishwanath. Biosimilars have been a boon for a country like India, where we struggle with such a low per capita income uh, to serve all our patients. The greatest challenge with biosimilars in the country is our lack of rigorous clinical trials before the regulatory approval comes through. Many times it's only a pharmacokinetic bioequivalence study. That is something that concerns me, and many times we wonder whether the drug is really working when patients progress. So I think that is something the regulators will look into more carefully, and we hope to get more regulated biosimilars soon in the country.
Yeah, perfect. Like you said, the importance of bioequivalence studies, regulatory frameworks, probably an international harmonization, FDA also having a role in probably regulating the way biosimilars are actually approved. All these things are points which can improve the efficacy of biosimilars. But like I said, as a LMIC oncologist myself, I feel biosimilars have significantly improved outcomes and the access to cancer care in a country like India, I'm sure Philippines and Nigeria as well. So, Dr. Ibraheem, this is something which I picked up specifically from one of the global webinar series and one of the Nigerian oncologists who spoke. So there is a lot of geographical variation. MSI high colorectal cancer is generally 5% in the rest of the world. It's 28% in Nigeria, but the awareness about immuno-oncology is very less. So, and also importing drugs, pharmaceutical supply chain issues, several issues are there. Any quick thoughts about this? We just have 2 minutes more and then wrap it up.
Okay, perfect. So here's the thing. First of all, Nigeria, our insurance does not cover cancer treatment at all. And then when we look at physical barriers, the roads to access hospitals is a problem. Even importing the drugs, you can be, and especially for drugs that have to do that, there's issues about lights, there's issue about drug theft, there's issue about actually diversion of drugs sometimes into the private market, and there's issue about lack of awareness. So it's a whole lot of multiple issues that we have ongoing, and then the foreign exchange and instability within the region, and then the inability to actually truly distribute. Sometimes we have these problems whereby you see that in some institutions, the drugs, even if it gets into the country, is just limited to an institution. And the question is, how do we address this? We also need partnership, the private public partnership, to be able to address this, hopefully working with the government to make sure there's light all the times, making sure that maybe we can get free importation of these drugs and actually prioritizing the importation of these drugs.
Perfect. So last thoughts from Dr. Roselle. So there is of course a time gap between the use of new drugs in high income countries and LMIC. We are all practicing in LMIC, and we've seen so many new drugs getting FDA approved, but it comes to countries like India and Philippines after years. What do you think about this, and how do we think we should work with experts like Dr. Lopez and uh, create a solution for this, come up with a solution?
Right, I agree. We should have a very strong uh, uh, coordination with the government, because the local regulatory are the ones really in charge of the approval, and we should set up some system in terms of fast track approval, just like what they're doing in the US and in the Western part. So it takes really years for example, an immunotherapy or a biologic drug to be approved and to be available in the market. And that is really limiting the access of our patients. So there should be more information that the medical society should collaborate with the local regulatory and sort of really giving them that impression that any delay in the approval of the drug will compromise the overall outcomes of our patients.
Perfect. And the last question to Dr. Lopez, you spoke so much about the Atom Coalition. I think last thoughts from you before we wind up this panel discussion.
The important thing I think Dr. Gadgeel mentioned, which is we need to work in a comprehensive, holistic way. I mentioned just medications, but it is clear that we cannot work on medications alone. We need to have a system where patients can get diagnosis, pathology, molecular pathology, and so on and so forth. And what we are trying with the ATOM Coalition is to plug one gap, but we are working on molecular testing as well and trying to make it more affordable in a way, at least for diseases that are relatively common. So more on that will be coming in the future. But I think the approach is we need to bring people to the table together. We cannot blame pharma, we cannot blame government for not paying or pharma for not having better prices. We truly need to get everybody to meet in the middle, and that's what we're trying to do with ATOM. So keep in mind that we will likely get to talk to many of you and ask for help as things move forward. And so thank you very much for having us here today.
Thank you, Dr. Lopez, for those wonderful thoughts. In fact, I would like to conclude with this saying. It's a Sanskrit saying. So, Vasudeva Kutumbakam, which means the world is one family. It's a powerful concept from the ancient Indian philosophy. Unless we bring this concept into the field of cancer medicine, we will continue to have inequitable cancer care. So, hoping that we move towards this goal. Thank you so much, all the panelists and the experts. It was a wonderful panel discussion, and I learned a lot from all of you. Thank you so much.
This was an excellent panel discussion moderated by Dr. Vishwanath. We head to the next panel discussion moderated by Dr. Westin from MD Anderson, Head of Lymphoma Clinical Research Program from MD Anderson Cancer Center. And we have panelists as Dr. Guru Sonpavde, Medical Director of Genitourinary Oncology and Bladder Cancer Research and Advent Health Medical Group, Orlando. We have Dr. Jasmine Kamboj, who is from Mayo Clinic Health System. And from Kenya, we have Dr. Chite Asirwa, who's the CEO and Executive Director of International Cancer Institute and a leading global cancer control program in leader for global cancer control program in Sub-Saharan Africa. And Dr. Maryam Lustberg, Chief of Breast Medical Oncology at Yale Cancer Center. I'll be handing over to esteemed Dr. Westin. Thank you, sir.
Wonderful. Thank you very much. And thank you for using a picture of mine where I had a lot less gray hair for that introduction. That's always appreciated to have the younger, less mature version of yourself shown at a webinar. So that's wonderful. So I am thrilled to join you all today. Yes, I'm thrilled to join you all today and to have my esteemed panelists help us to discuss clinical trials in the US and lower middle income countries to see how we can better work together to achieve the vision that Dr. Vishwanath just mentioned about having the world being one family, to learn from each other and to help our patients in more effective ways. These are my disclosures, which we won't cover any medications that are relevant for this, but I do clinical research in the Department of Lymphoma Myeloma at MD Anderson Cancer Center in Houston, Texas. As you've heard in the introduction, we have a great panel of experts, both from the US as from international countries that are going to help us to better understand clinical trials. And I wanted to kick it off with a very brief snapshot of what clinical trials look like at a large academic center in the United States. Obviously, this is something that we cannot replicate the same clinical trial setup at each center, at each hospital, in each country around the world. But just to put into context, what does a clinical trial team look like at a place like MD Anderson, which is a unique and very large tertiary cancer center in the United States? We have a philosophy on my clinical trial team where we view clinical trials to be our best weapon against cancer. There's a perception both from patients as well as sometimes from oncologists that clinical trials are reserved for patients who are multiply relapsed, who are at the end of their cancer journey, and before we go to hospice or palliative care, maybe we'll try a clinical trial to see if a brand new drug has any benefit in patients with cancer. That is not the majority of patients who are enrolled on clinical trials. The majority of patients who enroll in clinical trials at a center like MD Anderson are either newly diagnosed or have multiple treatment options, and we view the clinical trial with the newer medication, either by itself or in combination with other treatments, to be the best weapon. We have a team that's dedicated only to work on clinical trials. We have a research staff of approximately 150 people in my department, just as one department at a large cancer center, that only work on clinical research, and that's research nurses to advanced practice providers, research data coordinators, regulatory coordinators, and we have more than 80 clinical trials open at any given time. Some trials will open, others will close, but that's the large number of trials for lymphoma and myeloma patients that are available at our center at any given time, ranging from phase 1, brand new, finding the correct dose and the toxicities of those doses, all the way to phase 3, where we're randomizing and comparing a standard treatment versus a new treatment. And of course, this is an audience that knows all about clinical research, but this is what our team looks like at MD Anderson. That is not going to be replicated at centers in the US for all places, or certainly in lower middle income countries where clinical research is obviously still a priority, but doesn't have the ability to have a team that looks like this. So I wanted to kick off our panel discussion with our experts, not from the US, but Dr. Chandrakanth as well as Dr. Asirwa, who are going to tell us a little bit about the clinical trials in their setting, as well as barriers for clinical trials, the challenges for actually enrolling patients onto clinical trials or having a clinical trial program. So Dr. Chandrakanth, I don't know if you're available to kick us off here and tell us about what are the barriers for clinical research that if you could overcome them, things that are achievable, not things that are immovable barriers, but things if you could address them that would allow you to have more access to clinical research for your patients.
Well, thanks for the question, Dr. Jason, and I would thank Dr. Vishwanath for having me. It's my pleasure to be there in front of you all. Well, I work in a typical corporate hospital in India. So 99% of our time in practice goes for patient care and less than 1% for research. So me thinking of doing an investigator-initiated trial is, I don't like it because it's painful for me, right? Because the reward which I'm going to get by putting that extra effort is not that appreciable. And secondly, to get an academic recognition, being in a corporate hospital, so we tend to get into some soft clinical trials, may not be practice changing, but to just get some recognition, we get into some company-sponsored clinical trials. So the time which we dedicate for a clinical trial per se is almost negligible. We end up signing the papers and just check the inclusion criteria, and whenever there is an SAE, then we come into it. Otherwise, it's routine. So the time that we dedicate for a clinical trial is negligible because majority of the time is lost. Not lost, I think it's only for patient care because of the mere numbers that we see. And secondly, the acceptability of clinical trial among patients in our country. So clinical trials, the moment I counsel even for a phase 4 study where the drug is available free and it is marketed, even for that, when a patient just reads out, I have to sign a consent form, they still perceive it as an experiment that is going through them, that I'm a guinea pig. So the awareness among patients is not that much. Even though as an oncologist, I explain, oncology is a developing science. There is no standard treatment. It evolves over a period of time. Even then, the trust the patients have, their very thinking is still primitive. So, so the clinical trial awareness among patients is not there. So there is a challenge, both as an investigator-initiated trial or also dedicating time from the investigator, and also there is a challenge from the side of the patient to understand the importance of a clinical trial. So if I counsel 10 patients for standard of care phase 4 study, I end up recruiting less than 50% patients. So in spite of me stressing that this is the treatment that you're going to take even if you pay out of your pocket. So that is a challenge which I face in my clinical practice. Thank you. Thanks once again for hearing me.
Thank you for joining us and for sharing that perspective. That is true in my practice as well, that patients are often hesitant for clinical research. And I think if we don't bring it up, then we can't enroll on trials. But it is a challenge when you're busy, when you have limited time to spend time for something that may likely not happen or is very likely not to happen. You kind of get a why try again if the last 10 times you've tried something, it didn't work, the patient didn't have interest in the trial, that 11th patient is harder to get the time and effort to ask. Dr. Aswar, in your practice, what are barriers? Are they similar to what we just heard, or do you have anything that it's different?
Yeah, thank you so much, and thanks for the invitation for this. Let me put my, sorry. I hope you can hear me. Yeah, thank you so much. So at International Cancer Institute, we have actually an entire research team. We have a group of, it's a multidisciplinary, both clinical and non-clinical. So we have a group of oncologists, some hematologists, medical officers, clinical nurses, palliative, patient navigators. We've got pharmaceutical technologists, oncology pharmacists, and a few pathologists. So we actually established the entire infrastructure for clinical trials from ground up. And we have data management, quality assurance, quality control, recruitment team, monitoring and all that, and even follow-up. So one of the things we noticed is that the infrastructure was a little bit lacking in terms of conducting quality clinical trials. Currently, we've done over 20 clinical trials, which are mostly pharma and one investigator-initiated study. And for the pharma ones we've done, these are just global trials that are in various multi-center. And we had to build an entire research laboratory infrastructure with refrigerators and negative 20 degree, whatever freezers, negative 70, temperature control and all that, and creating research pharmacy with alarm and temperature monitoring and all that, because this was so important for the pharma to actually agree to allow some of their clinical trials to be done here at International Cancer Institute. And about 10 years ago, we didn't really have any oncology clinical trial being done in Kenya. About 5 years ago, it was just International Cancer Institute and a private institution in Nairobi that were conducting clinical trials. And now we actually have about 10 centers or so that are conducting this. And part of the things was, can we actually ensure that we have cold chain? Do we have good trainings in terms of the research training? Do we have the entire team? Instead of just saying we need an oncologist, do we have research assistants? Are we able to manage data? It's very interesting that some of the things that were impediments were interesting things like even a stable internet network where you can be able to get into RevEDC and you know, answer or respond to queries, as well as making sure that you can hold several meetings so you can have whether off-site monitoring as well as site monitoring. Even things like logistics support, administration. So some of those things we actually had to develop them from grounds up that actually allowed us to be able to do this. And now we have 4 you know, breast cancer clinical trials, and we are doing phase 1, phase 2, as well as phase 3 trials. We have trials in sickle cell disease. We even have a phase 1b/phase 2 trial in cervical cancer. So we are able to actually conduct all these trials over time, but it requires a lot of investment. Some of the areas that we noticed was financial constraints, considering that some of the sponsors are not really interested in investing in Africa. They come and they say, you don't really have a space yet. And we're like, we need you so that we can actually create that infrastructure. And they say, we want to find an infrastructure of XYZ. So we can't be comparable to the US, especially in most of our centers in terms of that. Then things like quality data, where you actually keep proper data and where there is quality assurance as well as quality data control. Then we notice other things were regulatory things, regulatory and ethical approval. Sometimes there are multiple ethical bodies going through the same trial. So time to activation, my first clinical trial, esophageal cancer, phase 2 study, time to activation took more than a year. And you can imagine in some of the centers, especially when you're doing competitive recruitment around the world, they don't really have time to wait for you to actually do. So there are a couple of studies initially that by the time we were being activated, they were actually already winding down in most of the centers that we couldn't really even get our patients in. So we've noticed some of those, but it's been improving over time. And part of it is actually just calling the regulators and saying, can we have a meeting? Can we discuss some of these impediments to access to clinical trials for our patients? And considering that oncology, most of our patients, anyway, clinical trial is actually part of care and part of standard of care for majority of patients. Right. And so we've noticed a little bit of a shift. Obviously, it's still improving. The landscape is still not optimal. But I think right now, if I have a new clinical trial that is on my desk, we can actually say within the next 90 days or so will be activated. Then we also notice even when some of the sponsors were sending their trials over, they would actually send us towards the tail end of the trial. So if you are sending, when in other centers that have been open for the last 4 years, and now you only remain with about 6 to 9 months for it to close, when you give us, then most likely, it's unlikely that we'll have anybody on the trial. I think for us, there is an improvement, especially in Kenya. The landscape is improving, but we still have some of those challenges.
That is wonderful to hear the sequence there of having somebody who's busy and has a track record of having patients say no thank you on a regular basis, to hearing a program that's been built from the ground up to address these issues. And wouldn't it be wonderful if we could copy the International Cancer Institute model that's been developed that we just heard about and grow this in other lower middle income countries? This is a wonderful program that you developed, and I think would benefit not just patients locally, but patients globally, for having access to clinical trials and showing that the same medications that may work in a high income country work just as well in patients in lower middle income countries. So that is something that perhaps we could flag as a future CPOM meeting of how do we develop programs like the International Cancer Institute to be in other countries, and how can we learn from the excellent experience we just heard about. We have just a few minutes left. We've had so much wonderful discussion today that we could probably go on for another hour at least. But we have two experts with us. Dr. Lustberg is unfortunately called away and not able to join us. But Dr. Kamboj and Dr. Sonpavde, who are going to tell us a little bit about their thoughts on how the international collaboration can help address some of these barriers, things that we do in the US or in lower middle income countries that we could do better together as a partnership. Dr. Kamboj, do you want to start us off?
Sure. Thanks, Dr. Westin, and thank you for inviting me, Dr. Vishwanath. So even though we are spending $460 compared to like 50 cents that was mentioned before in Dr. Lopez's presentation, I don't think we're doing such a great job in terms of clinical trial access and enrolling and accrual. So I'm going to bring us all down to planet Earth in the US. We have 80% patients in the US who are treated in community. We have around 70% of the US counties that do not have a single active clinical trial open, and more than 90% US adult population still is not enrolling onto clinical trials. And I say all of this not to be pessimistic, but because we in the US are trying to figure out how can we improve these stats, right? We want to get this better. We want community and rural oncology clinics, which is, by the way, which is where I practice as a part of the health system at Mayo Clinic. How can we do better in the community and rural oncology clinics? And I do feel that there is a lot of opportunity to evolve those solutions into some of our low middle income country problems. So for example, I think it was a year or two ago, we at ASCO published a paper about decentralization of clinical trials. So is there a way we can leverage technology to have some of the bigger centers, which do have research infrastructure in place? In India, maybe it could be AIMS or Apollo hospitals, I'm not sure, but can we have like a hub and spoke model and use things like telemedicine to use those bigger centers to have better research opportunities in smaller, relatively remote areas, which will obviously in turn help enroll more patients, reduce inequity gaps, etc. The other thing we have talked a lot about in the US is, can we make the trial process a little more realistic and pragmatic? I mean, nobody is going to go on the trials if we have 20 eligibility criteria, which is quite frankly impossible to like, you know, we cannot check all the boxes if we have such a restricted eligibility criteria. So can we loosen our reins there a little bit? Which also kind of, you know, brings to the point, like, patients in the low middle income countries have a variety of different set of comorbidities. I know communicable diseases were mentioned before. How can we incorporate the specific challenges that come with those patients in those regions to lessen the restrictions around the eligibility criteria? And as has been mentioned several times in the presentation today, collaboration is the key. And when we talk about collaboration, I don't just mean like physicians and the research staff or physicians and the organization, but a key factor here is policy. And I want to highlight like how policy can have an impact. So for example, ASCO advocated for something called as Clinical Treatment Act for several years, which finally took effect in 2022, which now requires all state Medicaid programs to cover routine costs of participating in a clinical trial, in a qualifying clinical trial. So, you know, partnering with our lawmakers and regulatory agencies, partnering with our pharmaceuticals and industry partners is, I think, the key here. And again, partnering comes with the understanding, and understanding comes with bringing up the problems and talking about it. So I think Dr. Vishwanath has already taken the first step, and I'm so proud to be a part of this webinar. Thank you.
Thank you, Dr. Kamboj. Dr. Guru, do you have additional thoughts to share with us?
Thank you. I know we're short on time, and I'll make it really quick. I think that most points have been made. I think that the macro view, I think, as you heard over and over again, I think is the suboptimal infrastructure and essentially the regulatory issues. Also, I think these are the two twin major challenges that will take a longer time to solve. But I think what we could maybe address a little quicker is at the micro level, maybe identifying very committed investigators in even the low middle income countries. As you heard before, physicians are very busy treating a large patient volume in many of these countries and don't usually have time, but maybe there needs to be some better time protection in addition to the better infrastructure. And I think, you know, most of the trials are industry run these days. I think that there could be a role for some kind of a global cooperative group, like the cooperative groups we have in the US and Europe and Latin countries. I think that could be helpful to conduct trials that industry will simply not conduct. One last thing I will add is that I think that investigators in low middle income countries don't frequently get co-authorship credit, academic credit. And I think that that's something to consider and get these investigators involved in these cooperative groups and in the trials in leadership positions. And all this, I think, will help towards improving accrual and giving trial access to patients in low middle income countries. Thank you.
Excellent. Great points to both of you. Thank you so much. And as I mentioned, I'm sure we could continue to talk for several hours more, but everyone is busy. And I know at different time points around the globe, it's either quite late or quite early in the day. So I will turn it back to Dr. Vishwanath and the rest of the CPOEM team. And thank you for inviting me today. Thank you for the panelists. It's been a great discussion, and I look forward to future collaborations. Thank you.
Yeah. Thank you, Dr. Westin. This concludes the webinar, where we request Dr. Poonam, our CPOEM trustee, to give the concluding remarks.
Yeah, thank you, Dr. Vishwanath. So as we come to the closure of the first ASCO endorsed CPOEM Foundation webinar of the year, we would like to extend our heartfelt gratitude to Dr. Robinson, President of ASCO, for taking the time to deliver the welcoming remarks and setting the stage for such an important discussion and from a global perspective. Very special thank you to Dr. Lopez for his insightful talk, and to Drs. Westin and Dr. Vishwanath for excellent moderation. We also want to express our appreciation to our distinguished panelists, Drs. Gadgeel, Guzman, Ibraheem, Santhosh, Sonpavde sir, Lustberg, Kamboj, Chandrakant, and Asirwa for their valuable support. A special mention for Dr. Srilata Vishwanath for her valuable support for the execution of this webinar. A big thank you to Sarah and Jessica from ASCO. tireless efforts of Dr. Vishwanath, the co-founder and managing trustee of CPOM Foundation, whose vision has been the driving force behind this initiative, and his dedication to advancing global oncology education and fostering collaboration continues to inspire all of us. We're also very grateful for the support for our fellow CPOM trustees, and we look forward to having you all join us for the next ASCO Endorsed CPOM webinar in April, and which we will focus on the access to multidisciplinary tumor board across the world and the molecular tumor boards. Thanks a lot.
Thank you, Dr. Poonam, and thank you one and all. Look for more webinars with all of you.
Thank you so much.
Thank you.
Thank you.
Bye.